So the last presentation in this session is by Professor Velchev, Tips and Tricks for Successful Tips.
Okay, I think that radiologists in the rooms are very well know with this procedure, but for the rest of the endovascular specialists, it's a little bit an outlier, so it's not very frequently done. So just as an introduction, what is TIPS? TIPS is a hemodynamic procedure, actually, in a situation when the resistance of the hepatic circulation goes up. The blood is trying to overcome this, and you have a lot of varices in different organs, mainly in the esophagus and the stomach. And unfortunately, this vein bleeds, and that's very problematic for the patient. And of course, some of these guys have also a severe cirrhosis, and they have ascites. So there are two most common indications. Those are bleedings from the varices and refractory ascites. So the philosophy of the procedure is you have somehow to connect the portal circulation to the systemic circulation. And because this vessel doesn't exist in nature, then you have to stent it in order to keep this ductus open. It's easier said than done, and you may see that usually the stent is starting in somewhere in the central portal vein, and it ends up in the vena cava or in the proximal hepatic vein. So it is very, very demanding procedure because you have one step which in the beginning was essentially blind, and that step is you need to cross from the hepatic vein to the pulmonary circulation. But before you start, first step, of course, is you have to look at your pre-procedural CT. It's very important. So never do TIPS if you don't have a good imaging. Why? Because on the CT you have a lot of information. First of all, of course, you have to check whether we have a big right ventricle and atrium and some signs of pulmonary hypertension. We can predict how easy will be done the shunt, and have in mind that if you put TIPS, you add something like 1.5 liters to the stroke volume. So if you have an old guy with the diastolic dysfunction, you can convert him to the overt heart failure. Of course, on the CT, you look for the unusual anatomy, you look for some branches, but first of all, and most important, you check for the left and right atrium and their dimensions. Then you need to have a patent portal vein. And of course, if you have already some thrombus in the portal vein, it's very important to know because this can complicate the procedure and make your life more difficult. And sometimes, something like 15 to 20% of the patient, you may see this. You may know what is this. This is the huge patent paraumbilical vein. And why it's important? Because those guys are usually with severe portal hypertension, and most of the time in this situation you don't have too much blood coming from the portal vein to the hepatic parenchyma, and fortunately those guys are very low risk for the most dreaded complication, which is encephalopathy after you put a shunt there. But you have already checked your CT. First step you do, you have to go and cannulate the hepatic vein. It's relatively simple. Usually you go from the right jugular, then you can select with a multi-purpose or Amplatz right catheter, go inside the right hepatic vein. It's very important to be on the right hepatic vein and not the middle or the left, because the path of the needle is much more straight from here. And already in this stage, you see that here we have a wire, and this wire is in the hepatic artery. Having a wire in the hepatic artery is one simple trick because it's very easy to do, but if you remember from the anatomy, the hepatic artery is always in front and a little bit below the hepatic vein. So having the wire there, you already have one dimension, and you know that if you go below this level, there is no big portal vein branches. The first trick I want to share with you, if you want to do tips, first of all, secure yourself with a nice echographic guy. Because if you have an echo, it's very easy for the beginners because, first of all, the echo can tell you whether you are in the right vein, and then having the puncture of the palmar or the portal vein, for the echographer, it's easy to tell you if you're going above the vein, below the vein, or you don't even reach it. And for you, it's very important because you can modify your needle and accordingly do a simple modification to be able to puncture the vein. Once you are inside, it's relatively easy. Once you're inside, you push some contrast. As you see, in this situation, we have a typical situation. You are in the central portal, and your artery is in front and below. So you can be very happy. Then you can put some wire inside and go ahead. But sometimes, just sometimes, you may see something like this. In this situation, you see a huge umbilical vein, and unfortunately, you don't see any intrahepatic portal branches. So in kind of a very advanced case of obliterative portopathy. And in this situation, the portal vein just coming in the hilus of the liver, and then the blood is coming out in the umbilical vein. Nothing goes inside the hepatic parenchyma. As I said, this is not a good situation, but for you it's an opportunity. First of all, because it's relatively easy percutaneously to puncture the umbilical vein and put a pictal catheter, as shown here. And then you know that if you're able to reconstruct and do the shunt and redirect the flow, you will have immediate relief of varices and bleeding, and the risk of encephalopathy is actually zero because your patient didn't have any flow in the hepatic parenchyma in the first place. You may see in this situation that once you have inside the pictal, you push some contrast, and under the fluoro, you may puncture the main body of the portal vein and then reconstruct the tract with a big stent. In this situation, you don't have to restrict the diameter of the stent because you want to have as much flow in the right atrium as you want to. And that's a big bare metal 12 millimeter stent, which is decompressing effectively the portal circulation. And now most of the blood is coming to the right atrium, and you have almost no flow in the hepatic vein. Unfortunately, this situation is happening also only 20% of the time. Other 80% you don't have this option. So next trick is once you are inside, you have to wire to the main trunk. So don't go to the periphery. Sometimes it takes a little bit manipulation of the wire. But in this situation, as I told you, your friend, the coronary wire and the hepatic artery just told you exactly, if you're not experienced, which way you should go. And once you're inside, you push some contrast and you're happy. And of course, in this time, you can measure the portal pressure and do some calculation to see whether they're in the right place. Of course, sometimes you have an extreme situation, like in this guy, where you have already a relatively curved first tips, which is closed, because probably you have a lot of angulations here, and probably this leads up to some turbulence and finally some new tissue growth, and you have closure of the stent. In this situation, you have very good markers when to begin and where is the main body. So what you do is just with your needle, you go to the proximal part of the stent and you reconstruct, and now you have a very straight way. Unfortunately, you have this D sign here, but believe me, for the patient, it's okay. We almost never saw a thrombosis of the intraportal part of the stent. And of course, before and after, you have to do some measurements. You have to measure exactly what is the difference between the pressure in the portal vein and the pressure in the hepatic vein. So if you calculate the gradient, never use rate atrial pressure, especially with the patient with a huge ascites, because intra-abdominal pressure is very high. And if you measure the pressure in the atrium, then probably it will overinflate the gradient, and the gradient is not between the portal vein and the right atrium. The gradient should be measured between the portal vein and the hepatic vein. And my last and final trick is, if you are so lucky and you also and you have this option, please just a second. I need to go back for some reason. Yeah. What I want to recommend for you, always film specifically the balloon waist, because the balloon waist gives you a very nice idea when is your puncture place, and those are the place of the very high fibrotic tissue. And usually, if you want to be successful, you need a tough stent coming through the portal vein, and you have to ensure that it is well opened if you want it to stay open. And of course, most of the time nowadays, this procedure done under general anesthesia. This makes your gradients a little bit unreliable. So what we rely mostly is the final angio. And in the final angio, you need to see backflow from the portal branches to the stent. And in best situation, the flow is mostly centralized. So most of the portal flow should go directly to the right heart. Of course, then you have to follow these guys. Fortunately, the follow-up is non-invasive, and you go for pressure, for velocity measurements on the day after the tips, and then you follow every 3 months. And if you have the increase of the velocity and you have some problems, you need to re-intervene before the tips closed. Because after the tips closure is much more technically demanding. If you have some proliferation, but the tip still open, it's relatively easy. Why? Because if you have thrombosis of the tips, usually you have rebleeding or recurrence of the ascites, which you don't want to have. So that's the game of tips for the beginners. I guess that if you start this procedure, you will have somebody to help you up in the beginning. But please have in mind that you need some tips and tricks to locate your target and for you to be easy to come up from the hepatic vein to the portal vein. Okay, thanks so much.
Any questions? Comments?
Okay. I guess nobody is starting TIPS program in the near future. Thank you.
Thank you. Yep, that was the last presentation.
Thank you. Thank you so much to the panelists, to the people who were so patient to hear us. We hope that this pathology, which was neglected for a while, will now come up in attention. And if you allow me, I would like to close this session.